Perfect. All right. Good morning. Welcome, welcome. This is our next edition of the International Thyroid Tumor Board. And we're very pleased this morning to have a team from University of Alberta presenting cases to us. We've got 3 cases to present this morning over the next hour or so, and a very distinguished panel that I get to pick on this morning, which is kind of what got me out of bed this morning. A good reason to go. I'm going to go around the circle and have folks just introduce themselves in a sentence, just probably on the order that you are on my computer. Dr. Harris, you're the left upper hand corner. You want to introduce yourself for us?
Sounds good. Thanks for the invitation to speak today. I'm Jeff Harris. I'm a head and neck cancer surgeon at the University of Alberta, and I'm the chief for the otolaryngology head and neck surgery service at our hospital.
Awesome. Welcome. Dr. Grewal.
Good morning, everyone. I'm Ravinder Grewal. I'm a nuclear medicine physician at Memorial Sloan Kettering, and I work with Dr. Tuttle.
That's her disclaimer. Sorry about that. Dr. Jacquier.
Good morning. I'm Jennifer Jacquier. I'm a clinical endocrinologist in Edmonton, Alberta, and I sit on the Thyroid Tumor Board at the Cross Cancer Institute.
Awesome. Fantastic. Dr. Hinther.
Good morning, everyone. Thanks for this opportunity. I'm Ashley Hinther, and I am the Head and Neck Surgical Fellow at the University of Alberta.
Awesome. Dr. Baloch.
Zubair Baloch. I'm a professor of pathology at the University of Pennsylvania Medical Center in Philadelphia. And thanks for inviting me.
Fantastic. Dr. Zafereo.
Mark Zafereo, head and neck surgeon at MD Anderson Cancer Center in Houston. Great
Perfect.
to be here.
And Dr. Alexander.
Erik Alexander. I'm an endocrinologist at the Brigham and Women's Hospital, Harvard Medical School.
Perfect. And Dr. Erkin is up here in the corner. Mark is.
Yeah, I am going to be taking the morning off here and let Dr. Tuttle run with us. And so I may chime in with a few burning questions, but take it away, Mike.
As usual, paying close attention as always. Okay, let's start with case 1. I think this was Jennifer. You've got the first case for us.
Great, thanks.
Beautiful.
And I have nothing to disclose. Okay, so my case is of a 37-year-old male who presented to his family doctor with a 9-month history of upper abdominal discomfort and a recently discovered mass in the left neck. He also had a 25-pound weight gain during the pandemic, as well as facial erythema, increased frequency of bowel movements, a rash on his torso and upper arms, and irritability. His past medical history was unremarkable. He took pantoprazole and some vitamins. His family history was also unremarkable. His blood pressure was borderline at 140/90, and his body mass index was increased at 38.9 kilograms per meter squared. On exam, he was anxious. There was significant facial flushing, telangiectasias on his face, a bulky thyroid with a firm left cervical lymphadenopathy, truncal obesity, an enlarged and firm liver, acne on his torso and arms, and pitting lower extremity edema. However, there were no mucosal neuromas, no evidence of a marfanoid body habitus or violaceous striae. And on initial labs by his family doctor, he had normal electrolytes, TSH, calcium, and glucose, but his transaminases were elevated 2 to 3 times the upper limit of normal.
Okay, let's pause there for just a second, Jennifer. Let's go Erik and then Mark. I mean, you guys see tons and tons of nodules that walk through the door. I mean, this one sounds a little more than, don't worry, you always accidentally find them. Sort of think out loud a little bit here, Erik, about how you're sort of thinking about what might be going on here.
Yeah, so I mean, you have a mass that is new or is growing or at least newly identified. He's a pretty big man, and many men can hide nodules up to 3-4 centimeters. So the fact that he notes it, we note it, it's probably something that we have to figure out what it is pretty soon. I think the other piece that catches my ear a little bit here are the other symptoms, the GI issues, the abdominal fullness, the flushing. We've been led a little bit with no mucosal neuromas. Is there a syndromic kind of process? But I think the kind of starting point in kind of the generalist area is to ask yourself if these are true, and unrelated, and you're dealing just with a thyroid nodule and something else, or whether this is all going to fit together as something unique.
Mark, knowing this is a thyroid tumor board, and this had better be thyroid if the guys in Alberta are playing along correctly, what is this going to be if it's thyroid with that other symptom complex? What are the things you're thinking about there, Mark?
Well, as Erik mentioned, I mean, the first thing I'm thinking is, are these symptoms related to the thyroid mass? Again, the first thing I would be thinking is along the lines of something syndromic like MEN, but we're told there's no mucosal neuromas, no morphinoid body habitus. So I'm gonna request an FNA here and defer to my endocrinology colleagues to work up these pertinent symptoms here.
Awesome. Okay, so we're down the pathway of not the usual thyroid nodule. This is a thyroid nodule with other symptoms. So could this be a medullary with other symptoms related some way? Could this be some completely other tumor that happens to have a nodule and lymph node metastasis? All right, Jennifer, so keep going with us.
Okay, great. So his family doctor ordered an abdominal ultrasound, which showed that his liver is heterogeneous and enlarged up to 21 centimeters. He has multiple hypoechoic lesions measuring up to 68 by 69 by 21 millimeters, likely metastases. His thyroid ultrasound shows a large mass in the left lobe with microcalcifications, TIRADS4, and there are multiple abnormal appearing lymph nodes in the left neck up to 19 millimeters. And here are the pictures of his ultrasound. On the left side, his right lobe, which is relatively normal, and then on the left side, a large mass with microcalcifications. He underwent an ultrasound guided FNAB of the mass and the left neck lymph node, which were both positive for malignancy and in keeping with medullary thyroid cancer. And here's his pathology.
All right, let's put Zubair on the spot here. I don't know how well you can see these, Zubair, but in a medullary, what are you looking for? What are the things that cytologists and like the buzzwords on the report we should be paying attention to?
So, as we know that most of the nodules that get biopsied are follicular cell derived, right? So they're coming from follicular cells and they do follow certain growth patterns. So you see either follicle formation, cohesive groups, or you see papillary formations. Medullary thyroid carcinoma. So I always tell my residents and my fellow colleagues that when something doesn't fit in that mold, you should always think of medullary. It should have medullary in the back of your mind. And the other thing is, we do not commonly see this, but sometimes you can have metastases to the thyroid also, and they can present as a single mass. So you should always think of this. Now, when you look at something like this, the first thing that really hits you between your eyes is these single cell patterns. The cells are very discohesive. So they are not really clamoring on each other as you see in the follicular cell-derived tumors. And they have this very round nuclei. And on the bottom right of my screen, you see the cells have very round nuclei, and the cell nucleus is kind of pushed to the edge of the cell. And that is kind of reminiscent of what you see on plasma cells. So if you remember your medical training, when you're looking at the blood smears and you look at the plasma cells, the nucleus was always pushed to the edge of it. So that's called the plasmacytoid appearance. Plus, when you look at the chromatin, it has this very kind of even distribution of U and heterochromatin. So it's a dark and white spots, and that's called like a salt and pepper chromatin, which is very typical for tumors with neuroendocrine differentiation. So you see these tumors, this chromatin in carcinoids and small cell carcinoma of the lung. So that when you have this, I think 99% of the time it is going to be medullary, but for cytology point of view, because this is much more of a serious diagnosis that you're making, it's always good to either, if you do not have a good cell block, to do immunostains to get a serum calcitonin levels to really confirm it. And also now you can send a part of the aspirate for calcitonin level determination. So this is actually a very classic picture of what is called the epithelioid type of medullary carcinoma, which is the most common cell pattern.
And Zubair, can I ask you that, like on the bottom here, it says spindle cell, and spindle cell to a lot of us always means anaplastic and rings the bells. Can you say a little bit about that spindle cell? And...
So the spindle cell medullary, which is very interesting because when you see the spindle cells, naturally spindle cell means in the thyroid, anaplastic carcinoma, or a metastasis from a sarcomatous somewhere else in the body, or even a thyroid primary sarcoma. In a younger age or middle age group, you're going to see another tumor, which is called Tuttle, which the tumor has thymic type differentiation, and that can also have a spindle cells. But what will be missing is the marked nuclear pleomorphism, really abnormal nuclei. You don't need a pathology residency. You look at those cells and you say, that cell looks bad. So anaplastic carcinoma will have that. Plus you will have necrotic background because most of these giant anaplastic carcinomas will have necrosis in the background. And sometimes you can even see mitosis. So that it will be missing in that spindle. So it's a clean spindle cells because necrosis is it's not that common in medullary. You do see it, but not that common on FNA specimens.
Okay, so let's go ahead, Jennifer. Let's do some imaging and some blood tests and see where we are.
Great, and it was stained for calcitonin and strongly positive. Okay, so he had a CT neck, chest, abdomen, pelvis, which confirmed a large 50 millimeter heterogeneous mass in the left lobe, also the left supraclavicular lymph node measuring 17 millimeters. There were extensive and enlarged lymph nodes in the superior mediastinum, resulting in a conglomerate mass measuring 70 by 70 millimeters. Also bilateral paratracheal lymphadenopathy and enlarged subcarinal lymph nodes, multiple poorly defined peripherally enhancing liver lesions, up to 60 millimeters, and 2 lesions in the spleen, each measuring 9 millimeters, suspicious for metastases. And here's a picture from his CT showing a large mass in the left neck. And then he had a gallium-68 dotatate PET CT, which was done about 5 weeks after his CT. And on this, his liver lesions had actually increased in size, and you can see the bulk of his liver involvement there.
Ravi, tell me, I mean, I'm used to PET CTs and FDG PETs. You guys are like labeling everything under the planet down there. So tell me, what's this gallium-68 DOTA study?
So gallium-68 dotatate is a PET scan for somatostatin receptor positive disease. This is approved for any tumors expressing somatostatin receptors. And it has been recently approved for the neuroendocrine tumors. As we can see, it is sensitive for medullary thyroid cancer. And the normal biodistribution that we see uptake in the pituitary, salivary glands. Thyroid can show mild diffuse uptake, which is a normal variant. But that being said, in a patient with thyroid cancer, we expect to see more focal uptake as compared to the background of mild diffuse uptake, which is just within the range of normal variation with gallium dotatate. Liver, spleen, kidneys, and bowel and bladder are also seen. So in this patient, we do see, as Jennifer said, these liver metastases as predominantly in the right lobe. Spleen is just showing physiologic uptake. Adrenals also show a physiologic uptake on dotatate. And also the pancreatic head and uncinate process show physiologic uptake.
So Ravi, in other neuroendocrine tumors, they're using this as like a theranostic, right? This is there, so there'd be the potential to label with lutetium or something. Can you say a word or two about that?
That's correct. So in tumors that express the somatostatin receptor positivity, we can use lutetium dotatate as a theranostic agent to target these tumors to zap them. And this has been done in the neuroendocrine tumors, which have high positivity for the somatostatin receptors.
All right, Jennifer, let's move through the next evaluations and then finally get to treatment. We'll pause there. So where do we go from here?
Okay, so he had a liver biopsy to confirm that the lesions were indeed metastatic medullary thyroid cancer. And then he had further investigations. So his calcitonin level was markedly elevated at 24,530. His CEA was very high at 2,798. Calcium and PTH were normal, and his plasma fractionated metanephrines were normal. I was suspicious of Cushing's syndrome, given his weight gain, his edema, his mood changes. His random cortisol was elevated at 837 nanomoles per liter with an elevated ACTH of 35.1. His 24 urine cortisol was extremely high at 4,385, which is almost 20 times the upper limit of normal. His AM cortisol after 1 milligram of dexamethasone was very high at 862. His 8 milligram dexamethasone suppression test was also abnormal at 712. He had an MR SELA to rule out a pituitary source of ACTH secretion, and this just showed a very tiny, less than 2 millimeter pituitary lesion, likely a cyst or an adenoma. And the other thing I asked the pathologist to do was to stain his liver mets for ACTH, and that was actually negative. He had genetic testing for a germline RET mutation, which was negative. However, he was positive for somatic RET mutation with the M918T variant. So the final diagnosis was metastatic medullary thyroid cancer with ectopic Cushing's syndrome. The first step in management was a surgical consult. He met with Dr. Harris's team, and surgery was not recommended due to his widespread metastatic disease, as well as the fact that he was relatively asymptomatic with respect to his neck tumor. He met with our medical oncologist, and there was a joint decision between the two of us to initiate vandetanib 300 milligrams daily. We would have preferred to start him on a RET inhibitor, but one wasn't readily available to us at that time. We would have had to wait about 2 months. We felt that we couldn't do that given his ectopic Cushing's and the increasing liver mets, and also due to lack of coverage for the RET inhibitors. I didn't initiate any additional treatment for his hypercortisolism, as otherwise he was doing very well. His clinical status was excellent. His blood pressure was stable. Electrolytes were stable. He received 5 milligrams of zoledronic acid for bone protection in light of his Cushing's. And this shows his response to treatment at 3 months. There was a marked reduction in cortisol from a baseline of 4,385 all the way down to 693. And there was some reduction in CEA and calcitonin as well. And his CT showed overall stable disease. However, there was a reduction in size in his left supraclavicular lymph node. He was tolerating the treatment very well with just minor side effects. Here's a picture of his CT before and after treatment. The left supraclavicular lymph node is highlighted. You can see that it has decreased in size. And so our plan at this time is to continue with vandetanib for now and repeat his CT in 3 months, and then switch to a RET inhibitor when his disease progresses. We're also closely monitoring his Cushing's and will institute additional treatments if this worsens, and I've listed some options there. Thanks.
So I mean, a very worthwhile case to look at, because Cushing's, I think, is a little more common in widespread medullary than a lot of us appreciate. It gets missed a lot. So this is not one of those rare things you'll never see if you see a bunch of medullary. We see this. And so I think that was sort of raising the red flags to begin with. Also typical that he had the 918 mutation, right? Somatic, that would be fairly typical. And also typical that vandetanib not only stabilized the disease, but helped get the Cushing's at least better under control. Erik, what are you thinking from here? You know, how do we go from here? Where are you on this one here?
Yeah, I don't want to overstep into being a medical oncologist, but I mean, I think the landscape of TKIs and treatment options in medullary, metastatic medullary carcinoma has rapidly expanded. I mean, in the decade we've had, there was not much, and now there's many things. And selpercatinib, I think, has really shown some interesting responsiveness. And as I'm sure Jennifer does, I always am alert with that extent of hypercortisolism for a low potassium that I'm following. Sometimes I'll place the patient on Bactrim because they can actually get sick from pneumocystis. So there's kind of a broad endocrine kind of approach to this, but I'm really pleased he's doing well.
Yeah, Mark, can you talk a little bit about that now, the landscape of some of these medullaries that were unresectable that carry these RET mutations? I think you guys are starting to do some neoadjuvant. Can you talk a little bit where that might be a role for a patient?
Sure. Yeah. Thanks so much for the question. I think it's a great presentation, Dr. Jacquier. Yeah, I think for this particular patient, I'm not sure that surgery will ever be sort of warranted because of the sort of the significant degree of symptomatic distant disease, most notably liver. So I think I actually, obviously starting that patient on vandetanib. You mentioned a RET-specific inhibitor would be another option. It's my understanding that the RET-specific inhibitors, at least selpercatinib, is now approved in Canada. That's what I heard, at least as of a week or two ago. So that's actually not that you would switch the patient now, but I agree with your plan just to keep the patient on vandetanib and switch when there's progression. But it is also potentially available as a first-line therapy in the future now as well, it seems. But in terms of so in terms of this particular patient, I doubt that surgery will play a role. But in terms of other patients with like this, who have local regionally advanced disease, and even if they do have distant disease, but maybe it's not quite so substantial and quite so symptomatic, many of those patients ultimately would have surgery. And we are seeing, we have a clinical trial now with the RET-specific inhibitor, where we're using it as Dr. Tuttle said, in a neoadjuvant setting prior to surgery. And we are seeing significant responses, as we typically see with the RET-specific inhibitors, resist responses, 30, 40, 50%. And that can make a big difference in terms of the surgical morbidity if you've got significant extrapleural extension or significant extranodal extension where you've got bulky disease that's sort of threatening the recurrent laryngeal nerves or other important structures in the central or lateral compartments. So that is something that we're continuing to study.
Great. Erik, I think the tough one here is the second bullet there, because, when we treat these, the vandetanib, the things, they get the Cushing's from, disastrous out of control, but they hardly ever cure them. Do you move toward the systemic therapies, the metirapones, ketoconazole? Do you move toward bilateral adrenalectomy? From a practical standpoint, what do you really do, Erik?
Yeah, I think you're seeing what is the response from the TKI, because and there has been a good response here. You'll see kind of where it goes, and I think, I do think the potassium losing kind of issue is often a driver in how aggressive you'll be. Ketoconazole is often a very easy thing to start with, though the patient's liver function tests I think were already elevated. So assuming those might come down or are not influenced by the TKI, that can be an easy way to start. Metiraprone is kind of the go-to. Life-saving can be the bilateral adrenalectomy, but it's a big deal. And so you really have to talk to your surgeons and think with the patient, but when and if that's needed for people who have, 24-hour urine cortisols in the, thousands, that really can be important. So they're all on the list.
Yeah, I'm a big fan of bilateral adrenalectomy. I get to see a lot of these that are, it's just, if they keep with Cushing's, it's just complicated for they need a surgery and they don't repair. They're on the kinases for a little bit. So I tend to move fairly early to bilateral adrenalectomy. I've never regretted doing that. I've several times regretted not doing that. As Erik was saying, I'm trying to get somebody treated and they've got all the complications of Cushing's with infection and low potassium and hyperglycemia. So that we have a fairly low threshold, especially now that they can do the adrenalectomy through the scopes from the back. It's a very straightforward procedure. So my general approach is get their cortisol better, like you did with vandetanib, so it's not a crisis. You can use a topamide. There's ways to get it down, but once that's down and they're fairly stable and the patient is relatively stable over a few months, they're not somebody that's going to pass away in the next few months, we move to that fairly early. All right.
Thank you.
Any other questions on that? Yeah, go ahead, Mark.
Yeah, real quick question. Two questions for Ravi. One is there's a comment or a question from the audience regarding the role of F-DOPA versus dotatate. And as a backup to the previous or follow-up to the previous question, is there hope that targeting the somatostatin receptor holds promise as a new approach to treating metastatic medullary?
Yeah, thanks for those questions. So there have been different tracers been evaluated in medullary thyroid cancer, FDG being one of them. Dotatate is another one, and DOPA, as mentioned, is another one. So FDG is usually sensitive when the calcitonin levels are greater than 500 or in the range of 500 to 1,000. Now, dotatate, as I said, is for tumors like medullary thyroid cancer, which can express somatostatin receptors, and they would show positivity. Now, DOPA PET is another kind of PET, which is a precursor of dopamine. This has been evaluated in various brain malignancies in Parkinsonism disease. So FDG and DOPA have like these complementary roles. So especially when the calcitonin levels and CEA levels are elevated, there is been some case reports and studies where DOPA has had better sensitivity than FDG for detection of medullary thyroid cancer. Now, if these tumors are expressing high avidity on the somatostatin receptor, gallium-68 dotatate, then definitely those patients can be treated with lutetium dotatate. And this is similar to what we are doing at present with the neuroendocrine tumors.
All right, let's switch over to Dr. Hinther's case. In the meantime, Dr. Coben put an important note in the chat that there are the new cortisol inhibitors that are very effective at treating the ectopic Cushing's as well. So that certainly would go on the list of options there. Thanks, so. Okay, Dr. Hinther, what do we got?
All right, well, thank you again for giving me the opportunity to present today. Just get this in presentation mode. So today I'll be presenting on microscopic papillary thyroid carcinoma that's non-FDG avid. So I have no disclosures. So this is a case about a 21-year-old female. She's healthy. She initially presented to her family physician with a clinically palpable thyroid gland, which subsequently led to a thyroid ultrasound in September of 2019, which following the results of the ultrasound, recommendation was to follow up with another ultrasound, which she had done in February 2020, and then again in December 2020. So in December 2020 was the first time that the ultrasound picked up microcalcifications with an irregular prominent lymph node that was inferior to the right thyroid lobe. So this then led to her undergoing an FNA of the right thyroid lobe.
All right, Zubair. The remote free consult from Philadelphia.
So, this is in contrast to the case we saw before. This is a excellent, you can correlate this. So this is, first of all, the cells are in a cohesive groups, which is very important, right? So this is not a single cell pattern. And this is more typical of a follicular patterned or follicular derived neoplasms. On the right-hand side, you can actually even, pathology is right, you can extend your imagination a little bit. You can see there's a finger-like projection. So it has a very sharp borders. So this almost looks very papillary looking. And if you look at the cells, the cell actually, the nuclei are very clear. They also actually, on the right-hand side, you can see one of the nucleus has actually a beautiful crease in it, intranuclear crease, which is an intranuclear groove. And I actually can see inclusion in this also. So it has cohesive grooves, chromatin clearing, intranuclear grooves, and it has that inclusions there, or that orphan, which is actually not a good term to use in public. It has those really clear nuclei. So to me, this is very compatible with papillary thyroid carcinoma or Bethesda 6. Some people may want to see more, and there's nothing wrong with it, and they may call it Bethesda 5 or suspicious for papillary carcinoma. But to me, this is diagnostic of papillary cancer.
Erik, in your nodule clinic, Erik, that you've got this nodule there, you've got some slightly atypical lymph nodes. What's your threshold to biopsy those lymph nodes? How do you make that decision when you think it's papillary and we're probably headed towards surgery? Think through that a little bit for me.
So I'm always in it first to figure out a diagnosis, and often I'll try and go after the primary lesion in the thyroid. The second thought, very much on the mind though, is to help the surgeon and guide the surgical extent of potential, if we think it's malignant, of potential resection. So that does get quite important because we don't want to open up the left or right neck unless we have to at times. And so I do think a quick biopsy of a lymph node is a very good thing. At times you can also watch that for thyroglobulin or calcitonin.
Mark, it seems like over the last 20 years I've been watching you guys operate, we went from nothing pre-op, just use our fingers, then everybody needs an ultrasound. And it seems like these days, lots of people are getting CT with contrast, something I call the Randolph effect. What sort of pre-op imaging, how do you decide on an average case like this, Mark, or whether you want a CT or ultrasound? How do you make that decision?
Thanks for the question, Mike. I do agree with Erik that biopsying that lateral neck lymph node would be important for surgical planning. And for patients who have either bulky thyroid disease, which in this case it's not particularly bulky, or lateral neck disease, I typically do go ahead and get a CT neck and chest. I don't see a lot of downsides to it. It also helps us sort of map the surgery a little bit better, make sure we know exactly where the lymph nodes are. Also, because once you start to have lateral neck lymphadenopathy, and this patient may or may not have central neck too, you want to make sure there's no lower central compartment lymphadenopathy, sort of in the border of the superior mediastinum, which you could otherwise miss on an ultrasound, which may be better seen with CT. Certainly, rarely patients can have retropharyngeal lymphadenopathy, which may not be seen well with an ultrasound. So I think those are some of the areas where CT imaging, not only for mapping, but can also pick up a few areas in patients with a little bit more advanced disease, pick up a few areas of disease that you wouldn't otherwise see on the ultrasound.
And just from a practical approach, Mark, obviously you get the CT scan. If there's disease in the compartment, you'll clean the compartment out. But what if there's only disease in level 3? I mean, do you really go up into 2? Do you really go out into 4 or 5? I mean, when you're in the operating, what do you really do? I mean, everybody always says we do these full lateral neck dissections, but it seems like there's quite a bit of variation. So how do you do that?
So in this case, it looks like there's a lymph node. If it is in level 3, I would go ahead and do levels 2, 3, and 4. We also oftentimes pull up the level 5B lymph nodes forward. And, typically you'll get, 30, 35, 40 lymph nodes in that specimen. I don't think there's a lot of increased morbidity to doing level 2. I'd rather do it the first time than have to go back a second time and do it. So we do tend to do a compartment-based levels 2, 3, 4, and 5B lateral neck dissection. I think one of the other interesting things is the central node. We wouldn't necessarily need to biopsy that up front because we would probably be addressing that surgically on the right anyway. This patient probably looking at a total thyroidectomy, central and right lateral neck dissection. But I think it begs the question, Memorial Sloan Kettering has always been on the forefront of more conservative therapy for thyroid cancer. And occasionally, this is maybe a little controversial. This is still a low to intermediate risk patient. And if this young lady were really motivated to sort of preserve her left thyroid, you could still consider a sort of a unilateral approach where you did a right lobe and central and right lateral neck dissection. That's another maybe not conventional option, but something to consider for a patient like this.
Yeah, I mean, we've definitely done that in people that I say were very motivated, or they know for sure they don't want radioactive iodine afterwards, or they're a professional voice user or something like that. So it's sort of not the norm, but we've been open to that. All right, Ashley, where do we go from here?
So after her FNA biopsy, which was only of the thyroid nodule, and no CT scan was obtained after that, she was referred onwards to the general surgery team, and she underwent surgery in March of 2021, of which was a total thyroidectomy and central neck dissection, as well as a right neck dissection. Unfortunately, the details of that surgery or slightly unclear, but from what I could gather from reading the OR report, it was from levels 2 to 4. And then we move on to the surgical pathology here.
Hey, you're it, Zubair. What are we seeing?
So on the low magnification, I really love it when people write the magnifications. So the low magnifications on the left shows you this tumor, and even from this level you can see these within the tumors. It's a papillary growth. So it's not forming, it's only forming few follicles, but mostly papillary growth. It is kind of a little confined. It doesn't have a true capsule, and on the you can see that there is a little bit of infiltration at the edges. So it is definitely papillary thyroid carcinoma. And you can see on the right lobe, low magnification, and the higher, I think they got switched, but the higher magnification, you can see the nuclei are there, papillary. So it looks more like a classic papillary thyroid carcinoma, or the classic subtype, which is the most common one. At this point, it doesn't have a capsule. I don't see a lot of infiltration. I also notice on the low magnification, and I'm kind of assuming that there may be an intralymphatic pneumoma body in there, but which actually on the second slide from the left shows a little bit of a pneumoma body sitting right there. So it may have a little bit of intralymphatic spread in the thyroid, but it looks like a classic variant of subtype of papillary thyroid carcinoma.
Okay, Ashley, go ahead.
Thank you for that. So this is the report that we received from our surgical pathologist. So multifocal papillary thyroid carcinoma of classic variant, with the largest focus being 1.5 centimeters. They did not see any ETE, LVI, or PNI, and they saw 11 of 13 nodes that were positive, with the largest node being 1.5 centimeters, and it was positive for extranodular extension. So the final stage of this case was PT1B, PN1B papillary thyroid carcinoma.
Okay, so take me through the rest. Yeah, so I'm gonna speed us up here just a little bit. So at first we're doing great, right? It's a 20-year-old with a papillary cancer and a few lymph nodes. And now, Erik, we've got a post-op thyroglobulin of 36 with a TSH that's 0.38. We've just gone from this is a piece of cake, don't worry, to what are you thinking now?
Yeah, I mean, you worry the thyroglobulin is higher than you want it, so there's probably some piece of likely tumor still in their lymph node or whatnot. I guess it brings up the rare specter of distant disease, though that thyroglobulin still is not in the hundreds or beyond. I usually reach out and talk to my surgeon and say, by chance, was there some piece of normal thyroid tissue you left in because of whatever, which does happen from time to time. And then you have this kind of decision point, which is, are you going to move forward with the radioiodine in a young person and ablate, or are you going to try and figure out if something is too bulky where you're kind of wasting your energy and you'd like to kind of still remove something before you ablate? So that's kind of my thinking.
Okay. So we
one additional comment, just looking, if you scroll back a few slides and just look at the pathology report, lymph node yield is something that's often discussed. This patient, had only 13 lymph nodes removed. I'm assuming had a central and a lateral neck dissection. So that wouldn't be a lot of lymph nodes removed for a case like that. You typically would expect maybe 30, 35 lymph nodes. There are, patient factors which affect the number of lymph nodes that are removed. Patients who are younger tend to have more lymph nodes. Thyroiditis tend to have more lymph nodes. There's also pathologist factors. So sometimes the pathologists, are not as diligent in looking through the specimen and sort of finding as many lymph nodes. But then there's also surgeon factors. And so sometimes surgeons maybe aren't as thorough, or they don't do as much of a compartmental based dissection, and so they don't get as many lymph nodes out. So that's one thing to consider here as well.
So echoing past comments there, we did some blood work. We did a CT chest to rule out any lung metastases, as well we did an ultrasound of the neck. And that ultrasound did show that she had right level 2 lymphadenopathy. Interesting enough, this same lymph node was present on her previous ultrasound prior to surgery in December. So given all of that, they did a PET CT, which didn't show any FDG avid disease in the neck. So discussion with the general surgery team and the endocrinology team, they decided to go for another right neck dissection. There was an intraoperative ultrasound performed based on the OR report. However, based on the OR report, it was described more as a node plucking procedure as a thorough neck dissection. So again, here's the surgical pathology from her second operation. And it showed 3 of 6 lymph nodes positive. So again, the total lymph nodes quite low, positive for E as well as PNI, and her post-operative thyroglobulin 27.9, so still high. So again, we're left with a microscopic non-FDG avid papillary thyroid carcinoma. And we're considering revision neck dissection versus RAI. At this point, she was referred on to Dr. Harris's team. And after discussion with Dr. Harris, as well as her endocrinologist and the patient, they elected to proceed with the RAI high dose. And this is her post-treatment scan. It does show some FDG avid or uptake within the thyroid bed, nothing really in the lateral necks. I know these are limited scans. And then again, we did a repeat CT soft tissue neck March 23rd. Nothing really specific is coming up here. We're not seeing anything obvious. So now here we are, we have a 21-year-old healthy female. She has an elevated thyroglobulin. Her most recent was done in January of this year at 30.1. It's non-iodine avid. So the question that we're really looking to answer today is, do we proceed with a neck dissection without any anatomical localization where we do have assumed disease that is still present in the neck?
All right, Erik. Yeah, this is a tough one, Erik. So 21 years old, you know, didn't have probably perfect imaging to start with. So we've got some persistent low-level disease, has a second surgery that's probably more node picking than anything. Probably not a false finding on the thyroglobulin in terms of antibodies, because it's been fairly consistent all along. So how are you thinking about her case now, Erik? Where do we go?
Yeah, I mean, so a few things jump out. One is a young individual. Boy, you'd expect some iodine avidity of anything that's left there. So it's just a little unusual, right? But I guess the bigger picture is, you know, young people tend to do well with well-differentiated thyroid cancer. 2 surgeries, 1 dose of radioiodine. I'm usually going to pull back a little bit here and try and follow with somewhat short interval sessions just to figure out kind of where this is going before I rush back in. I'm not a huge fan, of course, of any surgery without knowing what you're going to take out. So that's kind of where I'm at.
Mark, what are you thinking here?
I completely agree with Erik. I think at this point, I think she's young. You know, this is not an immediately life-threatening disease. I would sort of slow down a little bit. I'd make sure that you had very good cross-sectional imaging, you know, CT, neck and chest imaging, as well as ultrasound. And even if she had something small in her neck that was proven to be cancer, you know, something that was sub-centimeter, I'd still sort of try to kick this down the road in terms of another revision surgery and let sort of time be on your side and let things sort of manifest over time, because you want it, you know, if this patient is going to need a 3rd surgery, which it sounds like she ultimately will in her life, you want that to be a really good complete surgery, and you want to go into it with all the information. And so giving time is on your side, and giving things a little bit of time to settle down, and, you know, sub-centimeter disease to sort of grow and manifest itself can really help you when you go back in for that 3rd surgery.
Robbie, the role of radioactive iodine here, I mean, 200 millicuries versus 100, I mean, we make this up every Tuesday afternoon. What are you thinking about in terms of the radioactive iodine story here?
I think radioactive iodine in this case is justified given the number of lymph nodes involved with extranodal extension and perineural extension and the elevated thyroglobulin. Now, the question which popped up in the chat was a diagnostic radioiodine scan done prior to giving this 200 millicuries?
I don't believe there was a diagnostic radioactive iodine scan done.
Right. So the question is whether 100 millicuries is better than 200 is debatable. So I believe in our center, we would have gone with, you know, a dose in the range of 100 millicuries, given the, you know, the number of nodes involved, and we would have done a diagnostic RAI scan with iodine 123. So we give Thyrogen on 2 consecutive days. Then on day 2, after 2nd Thyrogen injection, we give 1.5 millicurie iodine 123 and do a diagnostic whole body scan with percent neck uptake on day 3 to assess what's the percentage of the neck tissue left and to see if we see anything else outside the thyroid bed. then based on that and based on the pathology and the risk stratification, we dose the patient on day 3 with iodine 131.
Yeah. So this is a great case to present because this is not an odd case, right? I mean, the only thing odd about this case is her thyroid globulin is 30 instead of 3. If this was 3, we would all say we see this every day. Young people presenting with N1B disease, despite the best surgery, only about 30 or 40% will go into remission, which means the majority will have biochemical incompletes or indeterminates. They'll have these low-level TGs. So I think what makes her a little different than the norm is the TG is 30 instead of the 3, 4, 5 that we would used to see. But as Mark said, I think you do good cross-sectional imaging, make sure you're not missing anything anywhere else. I think she's going to do fine. She's going to outlive me. I used to tell these people they would be at my retirement party. Apparently that used to be a lot more reassuring than it is now. So I don't say that anymore, but they're going to do fine. So I think it's just a matter of watching that trend in TG over time. And yeah, I certainly wouldn't be diving back in for another surgery right now because that would make her thyroid globulin go from 30 to 20 and we'd be in the same place. Any other questions about this one, Ashley, before we move on?
I think I'm good from my perspective. Thank you. I'm not sure if Dr. Harris had any questions.
No, thanks, Ashley. That's so just to conclude that case, that's what we're doing is we're just going to follow this lady along. The one challenge we do have is she had, before she was referred to our service, she's got a very unusual and now hypertrophic vertical scar on her neck, sort of a J-shaped thing, which she's cosmetically displeased with. So you might have to do a scar revision, but I think the neck dissection revision will wait until she's grown a little bit more obvious disease before we consider that.
I mean, that really is frustrating because clearly in this case, if we'd had good imaging the first time, the second surgery would have been avoided, right? Because that level 2 node was there to begin with. And when we started doing better cross-sectional imaging, most of the recurrences at 6 months and 1 year went away because they were dealt with at that first surgery. So I think that's a good one. All right, let's move to the last one. The last one's incredibly challenging. You got to have a good one for the end. Dr. Harris, good grief. Show us this case and let's see if we can figure out what it is.
All right, thanks again for the invitation. We got no disclosures. I'm going to start us walking down what we think is a gentle walk down the garden path here. So this is a patient who showed up in my clinic almost, I guess about 18 months ago, 46-year-old, perfectly healthy guy, found a thyroid mass that was first present a couple of months before he got referred to us, completely asymptomatic, otherwise healthy, palpated his neck. He's got a pretty large thyroid mass. It's very firm in its texture, no adenopathy that we can palpate, and endoscopy shows a normal vocal cord function. Here's the ultrasound that was done again about in June or July. So just shows a gland. They described it as a large nodule at 3.6 centimeters. Seeing many ultrasounds as we all do, I would say that's a moderate sized nodule. A couple of small lymph nodes in the neck that didn't really raise any concerns. So the impression on that ultrasound was just a large unilateral left thyroid nodule. They called it highly worrisome for malignancy based on that appearance from a community ultrasonographer. Here's the FNA, and I've got a bunch of these slides. So tell me where to stop, where you would like in terms of interpretation.
Okay, can we go back to the previous one?
Absolutely.
Yes, great. So this is a diff quick stain, which is done on on-site smears for evaluations. So again, this is a great example of what is called the single cell or a scattered pattern of the cells. So they are not forming any cohesive clusters, nothing like papillary or dimeric. But I can even see from this, the cells have a lot of cytoplasm in them. And when you see this, there are two things always come to mind. The first thing is oncocytic tumors. So the tumors which have oncocytes in it, which used to be called, I don't use that term often, is the Hinther cells. So they have a lot of cytoplasm in them and they can come out as single cells. The second one we all talked about is medullary. And anything else which has epithelioid morphology in the thyroid. Can we go to the next slide? And here you can see the cells are round. They're really not, the nuclei are not elongated. They do have a lot of cytoplasm. And some of the cells that again have that, the nucleus is kind of pushed to the edge of the cells. So it has that plasmacytoid type morphology. Again, the oncocytic tumors, which can be papillary or non-papillary tumors, will be in the differential. Is there a next one? I think there's another one, right? Yeah. So this is the PAP stain, which is actually very good. And I like to put a pitch for PAP stain because it really helps us to look at the chromatin or the nucleus of the cells. And this is done on alcohol fixed slides. Here you can see the nuclei are round again. They have a lot of cytoplasm. Cells have a lot of cytoplasm to it. There is no necrosis. But if you go on the left-hand side, can we go back to it? Yeah. So on the left-hand side, you see some of the cells and nuclei are kind of a little congealed. And this is almost kind of reminds you of apoptosis. So there is some kind of apoptotic stuff that is going on in the cells. And again, so oncocytic tumors, medullary thyroid carcinoma, it does have an epithelioid morphology, but I do not see necrosis and stuff. And the ultrasound features patient's age. I will not think of something like an anaplastic carcinoma. But again, you have to keep in mind that there are some tumors that can metastasize to the thyroid, then cause a single nodule. Is there a next slide? And this is again more, I think it's a smear, or I think it's more of a thin prep here. But here again, you can see single cell patterns. The cells are also, even you notice, are very monotonous. So they do not have a lot of nuclear pleomorphism, but they have every single cells look very similar. I see more and more apoptotic cells here. So which is more of a typical feature of something like a poorly differentiated carcinomas or high-grade carcinomas where you start to see single cell necrosis. Remember the cytology, you're looking at a very small sample, so you really have to use your imagination. And here again, I think you can go to that slide that you had. Yeah, that one. Now the other one. I think this. So okay, so definitely it's a neoplasm, and that will be my differential. To call something malignant, you need to have nuclear pleomorphism and necrosis if you're not seeing the nuclear features of papillary carcinoma. So this will be more on a Bethesda 5. I will not be able to call it outright malignant looking at that cytology.
Thanks. So pathology report we got was they called it papillary thyroid carcinoma and says it was reviewed within the department regarding that. So here's the question. So you have a healthy 46-year-old, 3.6 centimeter mass, which I thought, that we wouldn't consider that particularly large. My clinical examination, I noted on my chart, I said, I'm somewhat concerned by the patient's clinical appearance. FNA says papillary thyroid cancer. So I'd ask the panel, how would you proceed from here?
What are you thinking, Mark? We got about 7 or 8 minutes here, so
briefly, yeah, 3.6 centimeter Bethesda 5 or Bethesda 6, potentially PTC. I mean, I think it's a patient discussion. I certainly would offer the patient still a unilateral approach. Typically, I would also look at the lymph nodes ipsilaterally at the time of surgery, and I typically would sample 1 or 2 of those that are sort of incidental right there on a frozen section. There was some report on the ultrasound that there were some non-specific sub-centimeter nodes. Those are easy just to sort of send for frozen section intraoperatively. If those were positive, you could complete the central on that side as well, depending on how motivated the patient is for preservation of their other side versus the risk of having to go back for a completion. I think that's where the patient discussion really comes in ahead of time. Certainly, it wouldn't be wrong to do a total thyroidectomy if that were more in line with the patient's wishes here.
Sure. So I'm going to proceed here. So I was clinically concerned about this. And we are doing actually PET CTs rather than just simple contrast CTs quite routinely for thyroid cancers now if I'm concerned about aggressive disease. And we're actually putting some data together around that. We're finding they're much more sensitive than a simple contrast CT scan in terms of picking up aggressive disease and particularly lateral compartment adenopathy. So hopefully we can get that data out soon. So this patient, I was concerned clinically about the appearance. We went ahead with the PET CT scan and we'll get to the report, but there's a couple of things that we would look at. There's on that left side there, there's a probably level 2, level 3 node that's quite bright. This is the appearance on PET CT of that thyroid that was described as a 3.6 centimeter lesion on ultrasound that was done a couple months earlier, possibly esophageal wall involvement. Going fairly far down. I bring this picture up because there's comment on non-enhancing round nodules in the lungs that could represent metastatic disease, and then diffuse bone marrow activation as well. So there's the impression. Again, I'll kind of rush through it. So basically I've described everything. So probably bilateral level 2, 3, and 4 nodes that were somewhat suspicious, big mass in the thyroid gland, multiple suspicious pulmonary nodules. So with that discrepancy, again, I'll ask the panel here. So concerning looking PET CT scan, you've got a fine needle aspirate that's called the papillary thyroid cancer. Any thoughts on next steps?
What are you thinking, Erik?
You know, relatively young person. I mean, we used to say 45 years old was a cutoff in terms of AJCC staging. Now it's 55, young person, papillary carcinoma on your biopsy. You know, when Zubair's second read, so to speak, raised the kind of issue of high-grade features, that catches my ear a lot. You know, nonetheless, I'm still thinking the traditional kind of standard, which is surgery, radioiodine as a consideration, a young person. So I'd take the thyroid out.
So I appreciate that. That was a consideration. From my perspective, when I see this aggressive type disease, I prefer to get a second opinion and possibly more tissue for biopsy purposes to see what we're dealing with. Because this clinical picture in this patient with a straightforward papillary thyroid cancer isn't typical. So we did that, and we did a core biopsy. And so Zubair, I'd appreciate your opinion on this core biopsy.
So if this was a 60-year-old or 65-year-old and Mike or Erik were the clinicians and told me this is a diffuse infiltrating mass, my workup will be for anaplastic thyroid carcinoma because it has very monotonous single cell growth pattern. I don't know what stains you're showing me, but so naturally I will throw in first the follicular cell type stains, and which will be TTF1, thyroglobulin, and Paxate. Paxate is an amazing stain, which can most likely will be positive even when the TTF is negative for anaplastic carcinomas. So I will have, definitely, I will try to exclude those. What I'm really impressed by, which I think you can also on the H&Es, if you go back, yeah, that I think there was another one, high power of the H&E. If you go to that, I mean, there's a lot of monotony to those cells. And when you start to see that monotony, lack of pleomorphism, and really diffuse necrosis, then you have to really show it to your colleagues and start working this case up more. But to me, that will be the first goal will be, because this is most likely a high-grade malignancy, which was beautifully illustrated on FNA also. And this is where my work will go for this.
Great, thanks. And I apologize, I'm sort of expediting through because of time.
No, it's okay. It's okay.
Yeah. So, so we got to this final diagnosis after that repeat biopsy. So initially it was anaplastic thyroid carcinoma, but then this was sent to our colleague Sylvia Assa, who I'm sure you're aware of at University Health Network in Toronto, for a second opinion. She said that she was concerned by the appearance and felt that this actually might be non-thyroid metastases from another site based on her review, and was sort of steering away from actually a thyroid cancer, despite the clinical appearance, which showed to my mind that this was clearly originating from the thyroid lobe. So going through there, so now we have possibly anaplastic, possibly metastatic, large thyroid mass, probably local invasion, pulmonary metsadenopathy. So we sent this patient to our radiation oncology, medical oncology colleagues for this. And again, just sort of expediting things, radiation oncology had some commentary about likelihood of cure for what we're dealing with. Medical oncology, this was an interesting one. We actually were going to get another piece of tissue to see if we get a little more clarity on diagnosis. And I was asked not to do that because this patient, because of that pathology report out of Toronto, became a candidate for the Pembro clinical trial for an unknown primary disease. So that's what the patient was enrolled on and was put on Pembro. And so the treatment showed actually a pretty good response on Pembro. And The pulmonary disease appeared to have resolved. And what we're left with really is this. So this has gotten bigger, left thyroid mass, possibly esophageal invasion. So that's where we stood at that point. So I guess question to the panel again. So now you've got something that has responded, poorly differentiated cancer. We're not exactly sure what we're dealing with at that point. But things have resolved on Pembro to a certain extent, at least the pulmonary distant disease appears to have. So would you do anything further with this local disease, which appears to be progressing?
All right, we got 1 minute, Mark. Let me let you finish this up for us. So this is in the setting of a bad tumor, distant metastasis getting better. When would you really consider coming back and doing something to the thyroid?
Yeah, it's a very tough case, and much more than can be answered in 1 minute. But I mean, it looks like it's probably an anaplastic thyroid cancer. I mean, I think it requires a much more discussion in that regard. I mean, there wasn't anything else on the PET scan. I do want to say that, you know, instead of getting a PET scan, you could also start with CT neck and chest imaging. I agree that for a 3.6 centimeter thyroid mass that's firm, you'd want to get that. But arguably, you wouldn't have to go straight to the PET, although in this case, it worked out well. But from a cost benefit, you know, the cross-sectional imaging first may be a better standard for most patients. But I think, you know, in this case, with the distant disease, this is going to be a major surgery, as you know. Without studying the imaging more extensively, it's hard to know if this would require laryngectomy. Would this require a formal esophageal segmental resection with a free flap? And that's a big surgery to undertake in somebody who has distant disease, especially in the absence of sort of like a BRAF mutation or something where you feel like you can control that distant disease in the long term. So I think it's worthy of a discussion in terms of surgery, but there's a lot that needs to be dissected here in terms of further information.
Jeff, we're 1 minute over. Without showing any more slides, just take me to the end of the case.
Absolutely. So we actually did proceed with surgery on the patient, primarily because almost as a quality of life surgery, this was the thing we felt was most concerning. We were able to do a complete resection of that mass. CT scan showed that everything had resolved at least several months after the surgery. We did not have to take esophagus. We took esophageal wall, partial thickness, and did a free flap to reconstruct that. So he left the hospital speaking, eating well, drinking well. He did quite well with that. The end of the case, unfortunately, is that about 6 months later, he started showing pulmonary metastases that were recurring, and then local regional disease has recurred. That's where we're at right now. And repeat biopsy now is being sort of more pointed towards a de-differentiated into a true anaplastic thyroid cancer.
Yeah. All right. Jeff and Ashley and Jennifer, thank you so much. These were great cases for us to think about. Thanks for putting all the work together. To the panelists, thanks so much. We're done. We're finished. Let's all head back to work. Thanks, guys. Have a great day.
Good day. Thank you.
Thank you.